Okay, yeah, it's recording. If you don't like being recorded, well, tough luck. Fine. So, if anyone can't see the slides, tell me and I can reload them or something. There are 4 ways that you can test for any infection. Does anyone know how we can split those up? Grow it. Yes, growing it is one of the ways of doing it. Testing for antibodies is another way. There's 2 others. Checking for toxins in the blood, you can do that too. PCR you can do as well. So I like to keep things simple. So like split it into 4 different categories. So grow it, see it, stain it, and then check for any immune markers. And all of these examples that you've given are like come under these 4 categories. So culturing it is the same as growing it. Seeing it is like, again, you can culture and then look at it under a microscope. Staining it using gram stain or Zeal-Nielsen. Someone took control. Sorry, I'm going to need control of that presentation back. Fine. And slides have gone. And so we might as well talk a little bit about these stains, considering I've mentioned them. What's like the gram stain generally used for? What does the gram stain show us? If you had to simplify it. So not so much extracellular bacteria, but I guess there's some correlation. It's like how much peptidoglycan there is in the cell wall, right? Because you have the so you have the positive and negative bacteria that have different amounts of peptidoglycan in their cell walls, so different antibodies will work on them. And what's Zeal-Nielsen used for specifically? We spoke about it like last week. Yeah, tuberculosis is like the main thing. Brilliant. There's also other stains you can use for TB, but I don't really care about them. And they probably won't come in your exam. Fine. Okay. So, first case. The people written on in the chat. Any idea what this test X-ray is showing? Yeah, right lower lobe consolidation. Yeah. So I mean, you don't have an OSCE this year. Well, you probably won't have an OSCE this year, but if it came up in an OSCE, you'd be like, there's an increased kind of a pacification in the right lower lobe. That would be consistent with consolidation. So you said right lower lobe. Would anyone like to contradict that? Yeah, it's lower zone, not lower lobe. So now that you've corrected yourself, why is it lower zone, not lower lobe? Yeah, because it can be the middle lobe, and this, in fact, is a middle lobe pneumonia, not a lower lobe pneumonia. Lower lobe pneumonias, you'll lose the diaphragmatic edge here. So this is a middle lobe pneumonia because it's kind of the thing you've lost the most is the medial heart border here. Does that make sense? There's another presentation somewhere on like that drive I put in the group that shows like what kind of features to look out for each of the lobar pneumonias. You can have a look through. You can have a look through it in your own time. I'll post a link at the end of this if you want. Fine. And so if you examine this patient, I know you don't have an OSCE, but like still, it's really important clinically. What kind of signs would you elicit on examination? So I'll give you clues. So chest expansion, what would you say about it? Reduced on the side of the pneumonia, exactly. What about percussion? Dull to percuss, yes, exactly. And then dull, yeah, so specifically as Vikram said, depending on where the pneumonia is, it's dull. So if we have a middle lobe pneumonia, where is it more likely to be dull when you percuss? So if you think anatomically, the middle lobe covers both. Yeah, it's like it's a bit of the lower back, not too low where the lower lobe is. When you percuss the front of the chest, what you're percussing the most of is the upper lobe because they slant downwards. I can show you a diagram later, so don't worry too much about it. Fine. Breath sounds. What are you gonna hear? Crackles and bronchial breathing. So, what's the earlier sign in consolidation? Which one is the earlier sign? Bronchial breathing or crackles? So no, it is actually bronchial. It's actually bronchial breathing. So the first thing you'll lose is because you get all of this like exudative infectious stuff coming. Air can't travel through the smaller airways, so they only travel. You can only hear the noises through the bigger airways, so you get bronchial breathing. Later on, as the exudates kind of get thicker, but then you can still kind of breathe through them. You get those crackles. So yeah, bronchial breathing is first, then crackles. And do crackles only exist for the course of a pneumonia, or will they last for longer than the pneumonia? So yeah, they last longer. It's not necessarily due to fibrosis, but yeah, they do last longer. I don't know what the mechanism is. Can you explain what bronchial breathing is? Sorry, I wasn't very clear. So when you have consolidation in like the alveoli of your lungs, when you have a lower respiratory tract infection such as a pneumonia, those kind of occlude, so you can't hear the breathing noises from those lower airways. All you can hear is the airway noise from the bigger airways. The best way to like, if you want an idea of what bronchial breathing sounds like, if you put your stethoscope on your trachea, that's what bronchial breathing will sound like. So you get that tracheal breathing noise, but down in the lobes of your lung. Does that make sense? Cool. So yes, you get bronchial breathing and you get crackles. And vocal fremitus. Increased vocal fremitus, yeah. So the consolidation conducts your voice better than the air that is normally within your airways. Exactly, fine. So same patient later on has, okay, not the same patient because it switched sides, but this other patient has this. What is this? This is a left-sided pleural effusion. And how can you tell that this is a pleural effusion? What specific thing is telling you this is a pleural effusion? Yeah. So you have you have this meniscus on the left-hand side, and you have loss of the left costophrenic angle. Those are the two things that tell you this is an effusion. Okay, and again, if we run through the signs you will see when you examine a patient with an effusion, what's expansion going to be like? Decreased expansion on the side of the effusion. Percussion. Yeah, stony dull is like the term they love to use for percussion. Exactly. Breath sounds. Reduced breath sounds, yeah. Diminished. I was feeling fancy, clearly. And vocal fremitus? It is not increased, unfortunately. It is decreased. I'm not actually too sure as to why consolidation increases it and this decreases it. I'm sure someone who knows better physics than I do can explain it. But I just imagine it being like a wall of liquid. Would you hear any added sounds for pleural effusions? So you're unlikely to hear any added sounds unless the effusion is due to like a mnemonic process. Then you might hear some underlying crackles as well, but you won't because the breath sounds will be quiet. When do you hear the pleural rub? Wait, sorry. Consolidated mass has air pockets which echo sound. Okay. And yeah, pleural rub you can get in like pericarditis. That's one of the causes of a pleural rub. Does anyone know any other causes of pleural rubs? Just generally pleurisy can cause it. So any inflammation of the pleura will cause a pleural rub. I don't think you would hear it if they had such a present effusion, because when they have an effusion, it's just kind of hard to hear anything. Yeah, fine. Okay, so pneumonia is a lower respiratory tract infection, commonly caused by strep pneumoniae. They'll present with shortness of breath, a productive cough. They'll be systemically unwell. There'll be a fever, potentially. And these are the kind of investigations you want to be thinking about. Culture, in case it's got into their blood and causing them to be unwell overall. Full blood count, CRP. Chest x-ray so you can see any signs of consolidation. And then don't forget, you want to do culture and sensitivity. Management is determined by this dumb scoring system called the Curb 65 score that people in hospitals don't tend to use, because you can score very lowly and still be quite ill. So should we go through the aspects of the Curb 65 score? So can anyone tell me what C stands for? Confusion. How are you going to be able to tell if a patient is confused? So someone has hinted at 8 out of 10. Yes, exactly. So the AMTS is the score that you're going to use to ascertain whether or not they're confused. The AMTS is a pretty terrible test, but in year 4, that's all you need to know. And yeah, like the idea of the AMTS is you ask them questions like this, where they are, whether they're orientated to time, person, place. I know you don't have an OSCE, but I was about to say that learning the AMTS is useful for an OSCE, but you might not have one, so maybe not. Fine. Okay, what's U? Urea over 7. Yeah, I think it was that. I might have got this wrong on the slides. Oh wait, I didn't put it on the slides. It's okay. Yeah, urea over 7 or 8 or above. I think depending on which guidelines you look at, learn over 7. I think that came up in our exam last year. Fine. Respiratory rate is R. Does anyone know the cutoff? Yeah, 30. So like there's this really confusing thing. So the respiratory rate for the Curb score, the cutoff is 30, but there's another score that you'll learn called the Q-SOFA score for sepsis, where it's 22. So try not to get those confused. It's kind of hard to do, actually. It's kind of hard to not get them confused there. Fine. B, what does B stand for? Blood pressure, yeah. And what's the cutoff for the blood pressure? Yeah, below 90 systolic or below 60 diastolic. Yeah. And it's always that cutoff. Like, there are very few cases in medicine where you're not worried about a blood pressure at that level. So if you forget, the answer is probably that. Again, I think the Q-SOFA score uses like a systolic of 100. Learn the Q-SOFA score, by the way, because it's quite useful generally. Sepsis is important, as I'm sure has been drilled into you. And then what does 65 stand for? Yeah, age over 65 will score you 1. But there can be, so just another thing to keep in mind is young people compensate really well. So with a pneumonia, they might look really well until they suddenly fall off like a cliff. Old people will present earlier and will be more unwell. What do you think if say there's like an 80-year-old who has pneumonia, what do you think their presenting complaint is going to be? Yeah, exactly. Confusion. Or if there's an older patient, they don't really present like in the traditional way with like localizing symptoms. They kind of just present very randomly, and the presenting complaint is usually just they've been acting a little bit odd. Fine. Okay, and then you can split the causes of pneumonia into typical organisms and atypical organisms, and I'm sure a few of you have seen this table. I've highlighted strep pneumo because it's the commonest cause and the most important one for you to know. I've highlighted Haemophilus because we vaccinate against it now. But each of these has like, if you look at the case history for each of these organisms, they tend to have these extra features that might suggest to you a diagnosis of them versus the others, especially in an SBA. We'll go through some of the extra findings. Just one important thing: strep pneumonias are characterized by people being relatively well and they're just suddenly really unwell. It's very acute compared to the other ones. That might not come up in like an SBA, but in real life, that's like quite distinct of strep pneumonia. I put it in the notes for the slide, I think, anyway. Right, so now I have some like a picture round. So these are some extra clues telling you what kind of organism is causing this person's pneumonia. So what's the one on the left? Herpes labialis, yes, and that goes along with strep. It also goes in along with herpes simplex virus. Yeah, so cold sores for the layman, and you can get that in either strep pneumonia or you can get that in herpes simplex if they've got it as an STI. You kind of need to know this, but do you know which? So there's 2 variants of herpes simplex, two main variants. Do you know which of them tends to affect the mouth and cause cold sores? Yeah, perfect. Number 1. So HSV1 affects the mouth and causes cold sores. HSV2 causes genital ulcers. Fine. All right. And what's the thing on the right? Yeah, this is erythema multiforme. And which organism does this go along with? Mycoplasma, yeah, exactly. So mycoplasma is the pneumonia that causes lots of bizarre immune things, one of them being this rash. Do you know what hematological complication can come out of a mycoplasma infection? Does anyone know? Yeah, cold agglutinins. And yeah, it's so cold agglutinins, they get a cold autoimmune hemolytic anemia. It's just a random complication they get alongside any kind of mycoplasma infection. And Ritik has mentioned DIC. So disseminated intravascular coagulation is where you get lots and lots of random bleeding and random clotting going around your body. And any severe systemic illness can cause DIC, but like it wouldn't be like a common answer, but yeah, it could do it if it was severe enough. Fine. Any questions about those 2? I'll move on. You can just pass them anyway. Right. More abstract picture around. What's the thing on the left? How would autoimmune hemolytic anemia present? So autoimmune hemolytic anemia is likely to present as probably like a jaundice type picture, as they'd get like a unconjugated hyperbilirubinemia. We can do a session on hemolytic anemias, the best bit of medicine. Yeah. So yeah, this is Legionella, and why is this? Yeah, air conditioning units are a breeding ground for Legionella pneumophili. So if anyone's been on holiday recently in your SBAs, like always think about Legionella. And do you know what kind of other biochemical abnormalities someone with Legionella might get? Yeah, so it's a classical cause of low sodium, and it causes hepatorenal involvement. Hepatorenal syndrome is really serious. I would hope that they don't have it, but yeah, they can get involvement of both the kidneys and the liver. So check their LFTs; those usually go off as well. Fine. And what weird bacteria are we talking about on the right with the parrots? Yeah, chlamydia psittaci. Yeah, psittacosis. You don't need to know anything else about it. It's just a bit weird. If we go back for a second, which of the atypical pneumonias is most common? Do you know? As in, there's no way of figuring it out, sorry. Yeah, it's chlamydia pneumoniae is the most common atypical pneumonia. So if that ever comes up, there's your answer. Fine. And then what's this? So these, if we were to do this systematically, these are gram-positive. They are not diplococci because there are chains of them. So what gram-positive cocci forms chains? I mean, someone's already answered the correct answer, but does anyone else know? Anyone else? Yeah, streptococcus. Yeah, exactly. So streptococcus, you get like these strips of gram-positive cocci. I have a picture of Neisseria for you later. That has a very distinct look. Fine. And then here's the curve 65 score where I've got the urea wrong, but we won't talk about that. Fine. And your empirical management is going to be determined by the curve score. The higher the curve score, the more intense the treatment. So this is where I attempt to get you to understand our choice of antibiotics, probably to very little success. So the information you have so far is that the commonest cause of bacterial pneumonia is Streptococcus pneumoniae. What do you think? Why do you think we use amoxicillin? It's a very leading question. Yeah, so penicillins, the basic penicillins are very good against Streptococcus. So gram-positive cocci. Yeah, exactly. So that's why we're using that. And why do you think when it's a bit more severe, we might add clary? Yeah, exactly. So clarithromycin has a much broader range of action. It not only covers some gram-negatives, it also covers all of the atypicals. And any reason we add, and why do we add coamoxiclav once they're really unwell? What's the advantage of coamoxiclav versus just amoxicillin? Yeah, in case of resistance, when someone's that ill, you don't want to try and treat them and then fail because because it's resistant. Yeah, it's beta-lactamase resistant. So yeah, clavulinic acid, which is the additional thing in coamoxiclav, is a beta lactamase inhibitor. Fine. It is also broader spectrum, which is completely true. Do you know how it's broader spectrum specifically? Coamoxiclav covers one other really useful set of organisms that most things don't. Yeah, anaerobes. Pseudomonas, no. Anaerobes it does, though. It's one of the few bacteria that covers anaerobes. Fine. And I have a question for you. What does empirical antibiotic treatment mean, and when are you going to be using these antibiotics? Yeah, exactly. So before you've cultured, before you've got sensitivities, that's the only time you're going to use these antibiotics. Yeah. As soon as you get any results back, you will narrow, you'll hone in on some more specific antibiotics. Fine. Any questions on pneumonias? No, fine. You can just ask them as we go along anyway. So this is another random patient who's increasingly short of breath, and they spontaneously desaturate when they start walking. This is a classic SBA question that PassMed likes to throw at you. Yeah, this is Pneumocystis jirovecii. And what kind of pneumonia is this? Like, what is pneumocystis? Yeah, it's a fungal pneumonia. And what kind of patients would you expect to get this? Yeah, opportunistic infection. So people with HIV who might have immunodeficiencies or are immunocompromised. This is also very common in renal transplant patients, so don't forget about it. Yeah, exactly. And this is what their X-ray looks like. There are apparently cysts on this X-ray which give it its name, according to one of the RESP consultants at the WIT. I don't believe them. Don't ask me where they are. Right, time for bad puns. Why does the history suggest pneumocystis? Sorry, let's go back for a second. It doesn't suggest pneumocystis. The only thing that getting them to walk around and them desaturating is quite like specific for pneumocystis. Most pneumonias don't really do that. The aim of that case is more just if you see that, you should be thinking of pneumocystis. Does that make sense? Fine. If it was like in an SBA, they would definitely give you more information. What is Z? Okay, no worries. What kind? Right. So there's this patient. What kind of things are you thinking about? I know we're focusing on infection, but don't forget other medical causes. I'm glad everyone's enjoying the puns. Yeah, so you like I think the first thing when you're thinking of loose stools and vomiting is a gastroenteritis. Food poisoning is a cause of gastroenteritis, so it could either be, I mean, it's most likely to be a viral or bacterial kind of thing. Fine. What else could it be? I mean, it's a very short history, which makes anything else unlikely. But in the like, if I told you this was a young person, yeah, you'd also think about UC Crohn's, and you want to think about traveler's diarrhea, especially if they've come back from somewhere. Fine. So I like to categorize things, as I always say. So when someone has loose stools, how can you split that up? Bristol stool chart. You can use the Bristol stool chart. Do I know the Bristol stool chart? No. Yeah, I like doing it whether or not there's blood in it. Steatorrhea is also useful for hepatic causes. So if you look at the content, is it diarrhea or is it dysentery? So diarrhea is non-invasive and there's no blood in the stool. Dysentery is invasive, there's blood in the stool. And there's different causes of each. Aren't there two types of diarrhea or something? Yeah, they're here, basically. Does anyone know some what's the commonest cause of diarrhea without like blood in the stool? Just diarrhea. Norovirus. Yes, exactly. It closes down wards all the time. So bacterial causes are generally quite less likely unless you've eaten some funky food. And then you have some bacterial causes. We'll talk about these like just briefly. Does anyone know where someone gets Bacillus cereus from? Yeah, Noro. Yeah, rice. So Bacillus cereus, it's a cereal. Rice is a cereal. Yeah, reheated microwave rice. Exactly. C. diff can also have blood. I made a typo. So when do you get C. diff? Yeah, lovely. So broad spectrum antibiotics. All the antibiotics beginning with the letter C pretty much cause C. diff. Exactly, Vikram. Staph aureus is a pretty common cause of food poisoning. It's where do we find Staph aureus in the environment generally? Milk? I didn't know that. I assume you can get it in milk because it's everywhere. But yeah, skin. So like when people don't wash their hands properly, when you eat at a restaurant, if you get food poisoning, that can be like due to Staph aureus. So E. coli has different variants. The toxogenic variant, which is the one that causes diarrhea, there's another variant that will cause dysentery. And if they've got a long history or they're traveled anywhere like in Asia or Africa, you want to consider like Giardia. That'll be a much longer history. That'll be like 4 weeks plus. Maybe not 4 weeks plus, 2 weeks plus. Fine. And then for dysentery, which is invasive diarrhea, do you know what like? There's two like main causes of dysentery. Shigella, yeah, and the other cause also uses the same toxin pretty much. Yeah, it's the other variant of E. coli, the Shiga toxin producing enterohemorrhagic E. coli. So where does Campylobacter fit in? Oh, I forgot Campylobacter. Can't remember. I have a feeling it's non-bloody. Let me check for you there. Is it dysentery? It can be both. According to the handbook, it's dysentery. Okay, cool. Go by the handbook. It's what UCL will most probably use, considering your lack of teaching. Yeah, just go with the handbook. Fine. And what kind of things do you want to be thinking about when you're talking about Campylobacter? What other conditions can be related to Campylobacter? Yeah, so Guillain-Barré syndrome. So what will someone with Guillain-Barré syndrome classically present with? Yeah, so they can get like this weird like arthropathy. They can get enteropathic arthritis, but they get the main important thing for Guillain-Barré is the neurological findings. They get lower motor neuron findings in the limbs. It tends to be a lot of them. There's loads of different like variants of Guillain-Barré. So you can get a proximal one, you can get a distal to proximal one. So it really depends. But the main thing is the fact that you'll get like this transient, like almost motor neuron disease type picture. You'll get lower motor neuron signs. So exactly. Does anyone know what the variant of Guillain-Barré that goes the other way is called? Unlikely to come up in exams. It's fairly interesting there. So Lambert-Eaton is the opposite of something else. So Lambert-Eaton, tell me about Lambert-Eaton. Yeah, that's the opposite of myasthenia gravis. So Lambert-Eaton, you get. So myasthenia gravis, you get tiring of your muscles due to the anti-cholinesterase antibodies. Lambert-Eaton, you get different antibodies. So as you use the muscles, they get better and better. Yeah. So myasthenia gravis with underlying malignancy. So it's the opposite in terms of the like physiology, kind of. I think both of them can actually be caused by paraneoplastic effects, both myasthenia and Lambert-Eaton. Lambert-Eaton is more likely with lung cancers, though. Yeah, I think it's antibodies against CA2 plus channels. Yeah, fine. Yeah, so some people said Miller-Fisher, so that's one of the variants of Guillain-Barré. It goes the other way to the rest of Guillain-Barré. Fine. Let's talk about this E. coli, the enterohemorrhagic. What do you need to know about that E. coli for your exams? Does anyone know? That number is important, unfortunately. It's one of the few weird ones that you need to know. Yes, so it causes hemolytic anemia by causing hemolytic uremic syndrome. We'll talk about that in a bit, though. Fine. I'm going to move on, but if anyone has any questions, just drop them in the chat. So you generally treat with antibiotics. If they've got an invasive hemorrhagic type presentation, you're going to treat them with azithromycin. If they've got C. diff, you also want to treat that with metronidazole. What if treating them with metronidazole doesn't work and like they still have the same symptoms? What can you add? Yeah, you add oral vancomycin. So just remember, gastroenteritis, you need the infection is within the bowel, and the best way to get drugs there is orally. So IV antibiotics are generally a no-go. What will you want to be giving these patients IV though? Fluids, yeah, exactly. If they're not keeping down anything, you definitely want to give them fluids, otherwise they'll get dehydrated. Perfect. Hartmann's, yes. Hartmann's is great. Fine. Okay, another case. Again, in an SVA, you'll be given a lot more information, but I just want you to think about a range of things rather than just one thing. Yeah, poor Yusuf. It's okay. He knows I used him as a case. Yeah, so what you're worried about is meningitis. And why are you worried about the meningitis? Because it's dark, like the slide. Yeah, so being drowsy, it being dark, having this photophobia, you're always worried about meningitis. And meningism is this triad, really, of neck stiffness, headache, and photophobia. What is the most important condition that you want that will kill this person quicker? That would result in all three of these symptoms, but isn't meningitis. A subarachnoid hemorrhage, yeah, exactly. So if you definitely want to ask them if they've had any history of head like sudden onset headache. Encephalitis is like, so generally if you don't treat the meningitis, it can go on to encephalitis. So encephalitis is also incredibly dangerous. Fine. And then, so what is meningitis? It's in the name, really, isn't it? Inflammation of the meninges, and generally these people will present with meningism, fever, irritability, they'll be drowsy. And I think, like, in terms of management, I think these are the important things. You're going to do a CT anyway, because remember, you never do a lumbar puncture without a CT unless you're confident in your ophthalmoscope ability to rule out increased intracranial pressure. While you do your CT, you're also going to be able to rule it out, it being a subarachnoid, which is great. You start empirical treatment as soon as possible, and remember to do general bloods. So a thing they like putting in exams is like interpreting lumbar puncture results. I think there's some slides on the OneDrive, the SharePoint link I sent, on how to interpret results. I'm not going to go over that because it takes a while. Fine. And when do you not do an LP? What's like the one indication for not doing an LP in this case specifically? So increased intracranial pressure is, say we've ruled that out. Yeah, if you've done your CT and you see midline shift and there's signs of increased pressure, you do not do a LP. But yes, having this rash means you do not do an LP. Why does having this rash mean you do not do an LP? So coning is a risk when you have raised intracranial pressure. When you do an LP, you suddenly let out all the pressure and they might cone. So that's the complication of doing it when they have raised ICP. But in this case, so they're septicemic. That's true, but that's not what's stopping you from doing a lumbar puncture. You know what it is, so why do it before treating it? This is suggestive, but not. There are other causes of this rash. So yeah, it's to do with clotting. So this rash is caused by effectively disseminated intravascular coagulation. So if you do an LP, God knows when they're going to stop like bleeding. Don't do it if they have this rash. Fine. And so what is the causative organism when you see this? What organism are you worried about? Yeah, you're worried about the meningococcus, Neisseria meningitidis. And can anyone tell me the difference between meningococcal meningitis and meningococcal septicemia? Yep, exactly. So if it's spread to the blood, it's called meningococcal septicemia. If it's just causing the meningism, then it's meningococcal meningitis. So based off that information, is this meningococcal meningitis or is this meningococcal septicemia? This is not the brain, therefore this is septicemia. Yeah. So if you see the rash, that suggests that there's septicemia. Yeah, exactly, because it means that it's spread to the rest of their body. Fine. But I know that like in the context of this we're talking about infectious cases. In the context of that, this rash seems like it has to be meningococcal septicemia, but that's not necessarily true. There's lots of causes of non-blanching rashes. So how would you categorize the causes of non-blanching rashes? I need you to think outside of just infection. So any broad, so yeah, vasculitic autoimmune is one category. So yeah, exactly. What other categories can you think of? What infection is the other category, and then there's one other big category. Someone's not muted themselves. Hematological conditions, yeah, exactly. So now you just need to figure out what comes under what. So we've already talked about the autoimmune condition being vasculitis can cause it. So what hematological problems can cause it? Yes, TTP is one of those conditions. What's the other one that also goes along with TTP? It's basically presents exactly the same way, but it's caused by that weird E. coli. So ITP can probably cause this, but we won't talk about ITP because it's like a pediatric condition, so you'll talk about it next year. HUS, yeah. TTP and HUS. So remember, TTP is where you have an issue cleaving the von Willebrand factor, so you get lots of activation due to macromolecular von Willebrand factor. HUS is hemolytic uremic syndrome. I don't know the mechanism by which it causes stuff like this. It's basically when you have like E. coli 0157, you have an increased risk of this hemolytic anemia. These are both microangiopathic hemolytic anemias, so they can clog up arteries and cause these vasculitic rashes. Does that make sense? We can go into these in more detail, just not today. Because these are actually really interesting conditions and they do actually come up in exams. We talked about autoimmune. You can have like a primary vasculitis. You can also have secondary causes of vasculitis, as we talked about in the room talk. And also remember that like things like infective endocarditis can cause like an immune-mediated vasculitis. So that's why they get clubbing and splinter hemorrhages. So infection, we talked about meningococcal septicemia. Any gram-negative sepsis can present like this. what other really important condition can cause DIC? It's the infectious disease that kills the most people worldwide, and it's probably killed more humans in the history of like mankind than anyone else. Yeah, malaria. And yes, any severe sepsis can cause DIC. If it's severe enough, any of these can cause DIC. So absolutely don't forget about that. Fine. And then I'm not going to talk through this too much, but depending on the age of the patient, they're more likely to be infected by different organisms. The most common organisms causing pneumonia in most people you'll see are Neisseria causing meningococcal disease and strep pneumoniae again. There's a few ones that have, there are ways to remember a few of these. So young babies are at risk of group B streptococcus. Group B streptococcus is a commensal of the female genital tract, so that makes sense that they can get meningitis during birth. And then old people should just not eat unpasteurized things because they'll get listeria. Can anyone tell me why we use cefotaxime in the 0 to 3 month age versus ceftriaxone? There is a specific side effect for this decision. Biliary sludging is exactly why. So ceftriaxone causes biliary sludging. It'll worsen jaundice because most babies will get jaundiced at some point. You especially avoid it in premature babies. But you don't need to know that to be fair. You need to know about the biliary sludging. So why do we use ceftriaxone for meningitis? So biliary sludging is, so you have your biliary system coming off the liver. Ceftriaxone causes thickening of biliary secretions, so it turns into like a sludge that blocks and causes like an obstructive jaundice. That's what biliary sludging is. Does that make sense? Is that okay? Yeah, cool. Why do we use cephalosporins? So ceftriaxone and cefotaxime are both cephalosporins, and yeah, that's the exact reason. It crosses the blood-brain barrier. It has good CSF penetration, unlike most other antibiotics. It also has cephalosporins are really broad spec, so they can cover a lot of different bacteria. Fine. One other question: which other antibiotic can cause an obstructive jaundice? Does anyone know? It's the second most commonly prescribed antibiotic in the country. It's not Fluclox. I think it can as well, though. I think all of them kind of can. Coamoxiclav can cause biliary, can cause like an obstructive jaundice. One of the infectious diseases consultants at the Free last year got jaundice because he took some coamoxiclav. It was very funny. I'm sure it wasn't for him. Right. So what are these now? Now that we've been talking about meningitis for a while, what are these? The color, just imagine they're slightly more pink than they look. Yeah, these are meningococci. So Neisseria, classically, it's like these diplococci. Yeah, Neisseria meningitidis, you get these diplococci, and they're gram-negative diplococci. That's exactly. If you see this, if you see diplococci, you should always think of Neisseria. Right. Does that make sense? I've got more images to show you. Right, what's this? Don't give me a diagnosis. Tell me what you see. God damn it, you gave me a diagnosis. It's okay. This is a red swollen leg. Yes. Is cellulitis the only cause of a swollen leg? A red swollen leg. It is not. So cellulitis is one of the things in the context of this infection. Yes, this is cellulitis, but what other things could be causing the swollen leg? DVT, absolutely the most important cause for you to remember. and there is a cardiac cause. So it could be mixed edema. It's less likely to be red, but it would definitely be swollen. What else could cause a red swollen leg? Think. Yeah, so nephrotic syndrome could also cause it. Compartment syndrome sometimes can cause it. What other conditions go along with nephrotic syndrome? So nephrotic syndrome is where you basically have edema in the wrong places. So the conditions you're always thinking about are nephrotic syndrome, heart failure, and liver cirrhosis. So in heart failure, why could you get this coloration? What specific examination finding would this be if this patient had heart failure? So pitting edema would only explain the swelling. There's a specific examination finding when you examine a patient, and it's actually caused by chronic venous insufficiency that most people with heart failure will eventually get as well. And it would also be bilateral. Yeah, it would be bilateral. This is unilateral. I'm just trying to cover other things. So does anyone know what it's called when you get like... So Berger's test is a test of... I thought Berger's was arterial. I might be wrong. I can't remember it, to be honest. Atrophic skin is the correct answer. It's called... So if you have like chronic venous insufficiency, you get this awful rash called lipodermatosclerosis. You should Google it. I know you don't have an OSCE, but you will at some point see it, and it's very common in elderly people. And that looks almost exactly like cellulitis. So the most important thing, as Michael has already alluded to, is it unilateral or is it bilateral? In this case, it's unilateral. Lipodermatosclerosis. Let me type it for you. And this is unilateral, which makes things like DVT and cellulitis much more likely. If it's bilateral, those things become way less likely. What is lipodermatosclerosis? So I think it's like this weird rash you get due to like venous and arterial insufficiency in the legs. I don't know the exact mechanism. It's just one of those things that you can say when you walk into like an OSCE, and it makes you look really good because lots of patients with heart conditions will have it. So assuming this is cellulitis, what organism usually causes cellulitis? What's the most commonly found organism on your skin? Yeah, Staph aureus again. And Staph aureus is great from an exam perspective because there is only one antibiotic that works against Staph aureus. Does anyone know what that is? Fluclox is the only antibiotic that works against Staph aureus. So Staph aureus is... Oh, let's go back. Staph aureus is one of the bacteria that's intrinsically resistant to penicillins. It produces its own like beta-lactamase, so it's intrinsically resistant. It's not like a mutation that's making it resistant. That's why you have to use Fluclox. When someone says there's MRSA, what does that mean? So it stands for methicillin-resistant Staphylococcus aureus, but we don't use methicillin in a clinical environment. Yeah, it actually means it's resistant to Fluclox. Methicillin is like a lab-based antibiotic that they use for testing. They don't use it for treatment, but in reality, what it means is it's resistant to Fluclox. And what do you use if it's resistant to Fluclox? What can you use instead? So you can use teicoplanin, or more commonly, vancomycin. Yeah, so one of those two. So any infection, if you're worried about Staph aureus, give them Fluclox. If it's resistant, then you can switch them to either teicoplanin or vancomycin. And if it progresses to osteomyelitis, you add fusidic acid because that improves its uptake into the bones. Does that make sense? What is this rash? Lovely. This is, I mean, this could be erysipelas. Yes, this is quite likely to be erysipelas. If we weren't in an infection tutorial, what other things would you consider in your differential diagnosis? So yeah, this could be lupus. There is like labial sparing. Malar rash, yeah, definitely want to consider that. There is one other rash that looks very similar to this, that has the word lupus in, but is not associated with lupus. So it could be acne rosacea too, but it's gone beyond the nose. Also, you don't need to know acne rosacea for fourth year. So this could be lupus perineo, which is a sign of which systemic disease or respiratory disease? Yeah, lupus perineo. What disease? Yeah, the one you get in sarcoid. Exactly. But yeah, in the context of this tutorial, this is very much erysipelas, and it's a more superficial skin infection, which is why it doesn't cross the folds of the skin, and it's caused by strep pyogenes. So, strep pyogenes is not Staph aureus, therefore you cannot use Fluclox to treat it. What group of antibiotic did we say earlier is really good against strep? So amoxicillin would work against this, but amoxicillin is very broad spectrum, and we know that this is a specific type of strep. Therefore, you can use benzyl penicillin or Pen-V, depending on how bad it is. So benzyl penicillin and phenoxymethyl which is known as Pen-V, are basically the same drug. It's just one is oral and one is IV. And they're very good against strep pyogenes, which is also known as group A strep. But yeah, penicillin is the way to go. You could definitely treat this with amoxicillin. That would not be an issue. It's just we like to not use broad spectrums. And right, let's do a quick change of tack. What is this? What if someone is pen allergic? Oh, I can't remember. I'm sure you can find that on PassMed. Sorry. I'm sure I knew last year, but it's just not that useful to know at the moment. Fluclox can cover strep as well. Didn't know that. It might well do. That doesn't solve the problem of them being pen allergic, because they'll usually be Fluclox allergic as well if they're pen allergic. Yeah, this is malaria, and what gives it away? What's the giveaway with malaria? What would you describe these as? Does anyone know what these are called? What the description they would use? Yeah, ring form parasites, or like signet ring. Just be careful, because there's other things that look like signet rings in medicine, things that aren't malaria, things in other cells of the body. Fine. So malaria, what can you tell me about malaria? What causes malaria? Does anyone know what it's called? The parasite? Or rather the family? Yeah, so falciparum is the commonest cause. So what does it come under? There's like a family that causes it. Fugax is not. So yeah, Plasmodium is the cause of malaria. If you're going to learn one weird tropical disease for infectious diseases, learn malaria, because it kills lots of people every year. So it's the most important thing to learn, which is why I'm talking about it. What carries malaria? What carries this parasite? And what do we call something that carries something else? So mosquitoes, you need to know the specific mosquito. So the female Anopheles mosquito is what carries it. And what do we call things that spread disease? What's the technical term for these things? Vectors, yeah, exactly. Yeah. Why is it not moving slide? So the vector is the female Anopheles mosquito, and a useful thing to know is it breeds in less urban environments. Whenever you take a travel history from someone, you probably won't know like an exhaustive list of every condition in every country. No one knows that, not even ID I mean, some ID consultants know that. But the most important question you're going to ask them is, were you staying in a rural area or were you staying in like a city? Because the kind of conditions you can catch in a rural area are way completely different to what you'll catch in a city. Does anyone know what other mosquito-borne infections you're more likely to catch in like a city? If it's because malaria is a bit more remote generally. Do you know what conditions you're worried about if they're staying in like a major city in Asia? Yeah, so dengue and all the other mosquito-borne ones are more likely if they're in like a city. Rats. So dengue is mosquito-borne. Rats, you're thinking of leptospirosis, that I'm not going to cover because it's quite niche. And if you're interested, you can read up about it. I'll post what it's called in the chat, but you don't really need to know about it. Fine. And there's multiple different types of malaria. The most common and most severe version is falciparum. Does anyone, and a few of you said the other types in the chat. So is malaria more common in urban or rural? It tends to be slightly more rural. You can get it in both, but it does tend to prefer rural areas. So the Plasmodium genus has all of these species in. Why have so I've highlighted falciparum because it causes the most severe form and it's the most prevalent. Does anyone know why these other two are also highlighted? What's special about these? The only one you really need to know about is falciparum. It's just you need to know one fact about these two, which is why I've highlighted them. Yeah, reinfection. So these can be dormant within your liver and come back years later, and they can relapse and cause infection again and again. I've helpfully ordered these in the order of incubation period, should any of you wish to know. So no lazy has the shortest incubation period, malaria has the longest. Fine. And what two diagnostic tests can we use for malaria? Which ones were highlighted? So Ovale and Vivax both cause reinfections. Thick and thin films is first line. Yeah, and then what's second line? Does anyone know what's second line? It's just called rapid diagnostic test. You get results after 4 hours. It's not a replacement. You do it on top of doing these blood tests, or only if there's like an expert not there to analyze the blood film. There is one case where the rapid diagnostic test won't work. Does anyone know what that is? So what does the rapid diagnostic test involve? I have absolutely no idea. Not BCG. I think it can still work for falciparum, non-falciparum cases. I'm not sure about that actually. But yeah, in pregnant women, if the virus is in the placenta, it can still be causing symptoms, and they'll test negative on the rapid diagnostic test. It's just a weird problem with the test. It works for pretty much every other case. It's quite a good test. And then, can I explain thick and thin films? All you need to know for your exams in terms of thick and thin blood films is that their first line diagnosis, and the other thing you need to know is that's what you're looking for on the thick and thin films. You're looking for these ring-shaped parasites within the blood cells. Does that make sense? I can't really explain why they do thick and thin. I think sometimes you see them in the thin, sometimes you see them in the thick. I have no bloody clue, to be honest. Is that okay? Yeah, sorry. I'm not more useful. I am unfortunately not an infectious diseases consultant. I'm not going to bore you by asking you what the management is, but you're going to look at whether it's moderate or severe. If it's moderate, you use this thing called artemisinin combination therapy. If it's severe, you're going to give them this drug called artesunate, and you're going to give them quinines. I don't think they're going to ask you about that. What they might ask you about before we get onto prophylaxis is what classical fever feature do you get in malaria? There is one thing that you will always consider malaria with fevers. So swinging fever, so they might have a day of a fever and then a day off. There's different patterns depending on the species. Yeah, some of them are tertian, some of them are change every day. There's a few. How do you classify if it's moderate or severe? There's a classification in the handbook, I think, or you can definitely find it online. You won't need to know it. There's loads of different criteria. Viral load is is probably the easiest thing for you to remember. If it's a high viral load, it's more likely to be severe. Not viral load, just parasitic load. It's not a virus. And the other important thing to know about malaria is prophylaxis. There's loads of drugs and they all have side effects. The most common one that people take is called Malarone, which is a combination drug. Causes diarrhea, caution in pregnancy and HIV therapy. There's loads of other ones. I can post some notes on them if you want. I don't know why I made notes on them, to be honest. Vector control is very, very important, especially for people living in endemic areas because you can't take drugs long term. Nets, DEET are the two mainstays of preventing these mosquitoes from biting you. How much do we need to know about tropical infections? I think they don't come up a lot, to be honest. The really important one is probably malaria. The other ones don't really come up that much. If you have if you can give me a rough summary of the big tropical diseases, a one-line summary, that's all right for most of them. If you get me, you don't need to know a lot about them. And also, remember on the second slide, I talked about how there's 4 ways of testing for any organism. If they ask you anything, you can just go back to that and be oh, I test for this using one of these mechanisms, and one of those will probably be the right answer. I wouldn't worry about tropical infections too much. If you're in Who muted me? If you're interested, go for it, but you don't need to learn that much in detail about them. Yeah, I know, some snake muted me. Right. That's all the slides I made for the session.